Well, hi, everyone. Thank you again for joining us. My name is Dominique Bossard. I'm the Game Plan Advisor at the Canadian Sport Institute, Ontario. Welcome to CSIO's Podium and Parenthood, Fertility and Family Planning webinar series. Tonight's session is entitled Fertility and Disabilities, Understanding Reproductive Health and Family Building Options, and is proudly presented by our community partner, Markham Fertility Center. This is the last of 6 sessions in the series, and recordings can be found on CSIO's Resource Hub. Thank you so much for leading us in the webinar today. Over to you, Dr. Chum.
Thank you for the introduction, and we have saved the best for last. Today, we're going to talk about understanding reproductive health and family building options in those that have been affected by disabilities. A little recap on Markham Fertility Center. We currently have 5 physicians here. All are reproductive endocrinologists and infertility specialists. This clinic is physician-owned and run. We have a complete fertility care service in clinic, and we also collaborate and work in the hospital using the operating rooms, and therefore are able to provide all services and take care of our patients throughout their journey. We also offer deep sedation with anesthesiologists present, which means that we can offer care that is very comfortable and safe. We have a lot of affiliated clinics to make access easier for patients that are not close to us. And we recently have opened our satellite clinic in Barrie. Dr. Garcia and Dr. Wise have a sideline passion project, and they are the co-hosts of My Fertility podcast, which is also resource rich, helps with individuals and patients that are either going through this themselves, have navigated through fertility treatments, and also with a lot of others, allied specialists in this area, including psychologists, previous legal counsels, and people that are in this field that work alongside us. Now, today I've been given a very big topic to cover. The objective today is to go through as much as we can with mostly a big overview of this topic, because there's a lot of nuances in different case scenarios. Before we talk about these topics, we're also going to have a quick recap on the elements of natural fertility. We're going to have an overview of the types of impairments, discuss the challenges and barriers to fertility and family building, and then I'll explore those options and touch a little bit on the considerations in pregnancy, birth, and postpartum care. Let's talk about natural fertility recap. What are the elements of natural fertility? So for the purpose of this talk, we're going to talk about those assigned female at birth and those assigned male at birth as male and female. Now, we talked about the hypothalamus, pituitary, and gonad HPA axis in past talks, but their elements here are essentially the brain contains the hypothalamus and the pituitary gland. They produce hormones. And in the female, the key event is having regular menstrual cycle with ovulation being the point where egg is released. In those assigned male at birth, the key event is ejaculation, where sperm that is produced is being released. Ovaries are the gonads. The purpose of the ovaries is to carry eggs and to produce gametes, and in this case, oocyte. As the ovaries are growing and maturing follicles, it is also producing estrogen as a hormone. Post-ovulation, the dominant hormone at that point will be progesterone. In the male, the testes would be producing sperm, manufacturing sperm, and also producing the key hormone, which is testosterone. Now, there are additional work in those assigned female at birth, which structurally is the fallopian tube. The fallopian tube acts like a bridge, and this is where eggs and sperm would meet and fertilization occur. The fertilized egg, now an embryo, would continue to divide and slowly make its way down to the uterus for implantation, where placenta would grow, fetus would grow, and subsequently uterine contraction or cesarean section leading to birth. There are some key differences in male and female. From a reproductive point of view, the main difference in how we make eggs and sperm are different in male and female. In male, spermatogenesis, so the process of producing sperm, occurs continuously. Sperm takes around 74 days to be made and mature and enter the ejaculate. And because it is made continuously, we know that the male have a longer fertile lifespan. In contrast, those assigned female at birth, we are born with all the egg cells that we would carry for the rest of our life. So egg cell development starts in fetal life. Once we're born, we carry all the eggs. This is then paused in terms of its maturity until we reach puberty. So key events that happen in puberty is that we're now starting to have maturation and ovulation, and therefore start having menstruation as a key milestone in when we hit puberty. In puberty and beyond, menstrual cycle happens and follicles are recruited. And in these follicles that are recruited, these immature egg cells would now go through the maturation process. One be selected to become the dominant follicle, and that would ovulate. Because we are born with a finite amount of gametes, a finite amount of eggs, there is a finite fertility span in women because we don't make new eggs, we just mature them. The other organ that is key in natural fertility is the uterus. Unlike the ovaries, the uterus reproductive capacity is not reliant on hormonal production, but is more reliant on its response to hormones and therefore its receptivity in waiting for an implanting embryo. The uterine function essentially is to gestate and is closely related in its relationship to the implanting placenta. Switching gear, let's briefly have an overview of impairment types. Broadly, these are some of the common impairment types. We can think about impairment in muscle power, such as those affected by spinal cord injuries, muscular dystrophy, spina bifida. So this is where we see muscle weakness or lack of movement in that way. Maybe those that are affected by impaired passive range of movement, so they have increased tone, may be affected by things like contracture or immobilization. Limb deficiency is another category, and limb deficiency has a wide range of causative factors that led them to that point. This could be as a result of trauma in the past, could have been result of an illness that have resulted in a limb amputation. Another category that is related to stature. And mostly these are genetically related. So one of the conditions is achondroplasia or Turner syndrome. The last category here that I've included is those that are affected with intellectual impairment. And classification of intellectual impairment is just a little bit more broader. If we are thinking about reproduction altogether, broadly, we can think about this as three key elements or three key ingredients to final embryo and pregnancy and delivery. The first part is the production of gametes. Where is the source of eggs? Where is the source of sperm? How are they meeting is the next part, and the migration of eggs and sperm. The third part is the creation of embryos, how embryo is led to its key event where it would implant, develop, and become a pregnancy. The important thing to maybe touch on is that the source of eggs and sperm and uterus may not necessarily be in the same two individuals, couple, or it may involve third parties. But a lot of the care that you might find to be quite repetitive in what I will say today is that this is quite multidisciplinary in approach to get there. Let's talk about where there may be barriers and challenges in the making of the sperm or the maturing of the eggs. Now, To think about where things can go wrong and may not be functioning is to think about what normal looks like to begin with. So remember our production line axis that we've covered in normal cycle and natural fertility in one of the previous webinars. The picture that I've included here is this. In our brain, we have a hypothalamus. The hypothalamus would send signal down to our pituitary gland. The pituitary gland made up of different hormones. And the key hormones, one of them is FSH and LH. And they would act on the testes in male and act on the ovaries in female. In some examples, we can see eggs and sperm not being made or not being matured. Why? That could be one of two things. One is that the ovaries and testes are not getting the signal from higher up. So FSH and LH are not being produced in a high enough amount, and therefore it's not stimulating downstream for gametes, so eggs and sperm, to come out. The second possibility is that the brain is working just fine. It is stimulating downstream in this production line. However, the ovaries and testes are not responding. So let's think about some of the examples that may fall into these categories. In the scenario where there is a lack of signal from the brain, this could be because of previous traumatic brain injuries. This may be associated with individuals that are affected by cerebral palsy. That could also be commonly caused by external medication. So if you have external medication, it may stop the signal from where your brain is producing. Example of cases where the brain and the hypothalamus, the pituitary is functioning just fine, it's producing its signal, is producing the hormone FSH, follicle stimulating hormone, and LH, luteinizing hormone. But the ovaries and testes are not responding. Why? This could be because of gonadal failure. So in a way, if we think about the normal lifespan of a female, what would be a scenario that fall into this category? That would be menopause. In menopause, our hypothalamus, our pituitary gland are sending the right signals to our ovaries. But our ovaries now have gone through its complete lifespan. We are now not producing eggs anymore because there's no more. The reproductive lifespan has finished. In that scenario, it would not respond no matter how much FSH is produced. An example of this may be those individuals that are affected with Turner syndrome. They have a higher risk of having premature ovarian insufficiency. The old terms to describe this is premature menopause. There may be individuals that have had previous cancer treatment, and part of the cancer treatment include having chemotherapy or radiotherapy to the pelvis. These treatments could affect the ability of eggs and sperm to be made because of the toxicity of these drugs. So what are our treatment options? If at all possible, and there is a reversible cause, such as this is caused by medication that's taken externally, such as steroids, and that would be the most convenient thing to do, should that be something that we can remove. So if there's a variable reversible cause, then reverse that. But in majority of the cases, that may not be possible, or there may be something other than that. For example, if it was hypothalamic in nature, the ovaries have eggs, the testes have ability to make sperm, but they're just not getting the right signal from the hypothalamus or pituitary. In these cases, then replacing the signal that comes from higher up makes sense. So you can either treat that with a hormone pump, or you can treat that with hormone injectables. So they are FSH, LH, and also HCG. These are three main hormones that we use commonly in IVF treatment to stimulate ovaries, to stimulate the testes. This could be given in an injectable form. Provided that there's eggs and sperm cells there and the function downstream is still working, then that would respond. That replaces the function of what the brain would have done otherwise. These hormones, however, would not work if there's already ovarian or testicular failure. So downstream, the ovaries are not going to respond because it does not have eggs anymore. The same as if somebody's gone through menopause. In these kind of cases, then the options to discuss with individuals or patients are, would we consider the alternative, which is to have an egg donor or a sperm donor? The next step, if egg is available, the next thing is ovulation should happen in a regular menstrual cycle. It gets picked up by the fallopian tube and is waiting for sperm to come and fertilize it. Ejaculation is a key milestone event where sperm is produced, and intercourse would allow the sperm that is produced to be deposited at the top of the vagina. Sperm would then have to ascend the female genital tract, enter the fallopian tube, and there find an egg that is ovulated and fertilize it. Now, what is the barriers to embryo creation? Knowing that those are 3 events that need to happen. Potentially neurological disorders, spinal cord injuries that can lead to erectile dysfunction, can lead to ejaculatory disorders. There may be physical impairments for intercourse to take place, and this may be contractures. There potentially are pelvic structure changes. Intercourse may be painful, or there may be limited mobility for intercourse to take place. There are causes that are medication related as well. So if there are contractures, there may be use of things like muscle relaxants. There may be antidepressants that can affect libido. And even when all those functions are intact, individuals or couples may decide that that's not how they would want their eggs and sperm to meet, because they are at a higher risk of transmitting an inheritable genetic condition to their offspring. This may be associated to the condition they already are experiencing. The last thing is this. What we know is human reproduction, unfortunately, is not very efficient. There is a monthly fecundity rate. What that means is that we wait a whole month for a menstrual cycle to happen. Around the whole menstrual cycle, we have 5 to 6 days where our fertile window open, and we have to have intercourse around that time, and trying naturally can take time because the chances of getting pregnant is low per cycle, and is also age related to the egg provider. To counteract that low efficiency in human reproduction is to try getting pregnant, not just through one cycle, but through multiple cycles and over time. This may itself bring about some psychological, emotional challenges, because over time it may feel like a chore. It may be associated with pain. It may be associated with the feeling of harming from partners where this may not be comfortable for them. What are our options in these kind of scenarios? We should think about some modifiable variables if possible. If there's a reversible cause, and most of the time it is thinking about medication that may have led to those difficulties and barriers, or adding in medication to optimize it. In individuals that find it difficult to have intercourse frequently, we can consider thinking about time intercourse, where we use ovulation tracking, either through devices, calendars, hormone tracking, ultrasound scan, to maximize the identification of their peak fertility time. That means that we can maybe reduce the frequency of the timing of intercourse. Consider help with adaptive positioning and partner assistance in these scenarios. Other options when having intercourse is difficult, or there is an ejaculatory disorder, we may have to consider banking sperm, and then bank sperm be used in an intrauterine insemination procedure. So in an IUI, in short, sperm would be placed directly into the uterine cavity at the time of ovulation. So this maximizes the chance of egg and sperm meeting at the right time of the month. I have got a few more slides just to hone in a little bit more on spinal cord injury, because this is a unique impairment that has some uniqueness to how it affects men and women differently. In men, we can see that men that have spinal cord injury have a higher rate of erectile dysfunction and ejaculation or for sperm motility. However, there is some variation in the degree of erectile dysfunction and impairment depending on the injury level itself and how bad the injury is. And most of the time, we would have a urologist expertise on board to help. If the erectile dysfunction is not very severe, on occasion, we can consider using medication such as Viagra to help. In some cases, we can consider using electroejaculation. This is when a rectal probe is used to help ejaculation to take place, and then the semen sample will be collected and frozen. Other option is to consider surgically retrieving sperm, and then the sperm that's retrieved from that point of view will be frozen as well for future use. Now, how we can use frozen sperm really depends on how we collect the sperms and also on the collection, the count, the motility, and how much we're able to collect and store. In some cases, we can perform intrauterine insemination if the amount of sperm is enough. But majority of the time, if they are surgically retrieved, then the sperm amount would not be enough to just place in the uterus. And in those scenarios, IVF with sperm injection would be required. What it generally looks like in terms of options are this. In some cases, we can do an aspiration directly from the testes, and that would be a TISA. Or we can do an aspiration from the epididymis, and that's a PISA. So you can see a needle gets inserted to those areas and using a syringe to essentially aspirate, just the same as what you would do if you were trying to draw blood. Other surgical options is actually making an incision and going into the testicular tissue. In that scenario, you're extracting testicular tissue. The purpose of all this is to actually look for sperm under the microscope. And what we're trying to do is look for sperm that are moving, so motile sperm. Like I mentioned before, in majority of the cases, the sperm that we get from these procedures would not be adequate in terms of amount to place in the uterine cavity for it to go seek an egg directly itself. In this scenario, because the amount would be much reduced and they were precious to begin with because of the way that we're having to use a procedure to extract them, the recommendation then would be to use them in an IVF cycle where we would inject the sperm into egg that is retrieved outside of the body. In this scenario, then the female partner would have to go through an egg retrieval procedure after IVF stimulation. What about spinal cord injuries in women? Spinal cord injuries in women, slightly different. They can retain normal ovulation. They can retain normal cycles. But positional challenges for intercourse or examination may be a barrier. In these scenarios, options that can happen is that we can maybe try to figure out exactly when ovulation is going to happen. We can track cycles. We can use time intercourse. Or if there's no difficulty from a male factor point of view and there's enough sperm can be washed, concentrated, and placed into the uterine cavity by performing IUI. The most efficient out of all fertility options always going to be IVF, because in this scenario, what we then are doing is not waiting for one egg to come in that one menstrual cycle. We are intentionally using injectable hormones to drive multiple follicles to grow at the same time. And in IVF, those multiple follicles would hopefully contain eggs, and they would be retrieved from the ovaries outside of the body and be fertilized in a lab. Pregnancy is possible in patients that have had spinal cord injury, but this requires a great deal of specialist input, and having set this up with a lot of pre-pregnancy planning is key. Now, one unique complication of a spinal cord injury is a condition called autonomic dysreflexia. This is potentially life-threatening as in medical emergency. And this is because of an overreaction of the autonomic nervous system. In essence, with spinal cord injury, there is a disjointed parasympathetic and sympathetic nervous system disconnection, essentially. In this scenario, autonomic dysreflexia can be triggered by labor, contraction pain, delivery, can be triggered by things like having a distended bladder, a blocked catheter, having a urinary tract infection, or something as simple as having constipation. Like I said before, this could be life-threatening. The elevated sympathetic response can make your blood pressure go super sky high because it's unopposed. In the upper body, it can cause headache, flushing, blurred vision. In the lower body, you see this cold, pale skin to lower to the injury. So very different in which nervous system that's contributing to the symptoms. Lastly, we mentioned just now about heritable genetic condition. Conditions such as achondroplasia can be heritable in 50% of the time to offspring. And this may be leading to the disability that the individual is experiencing. Now, in this scenario, it's crucial to make sure that a geneticist or a genetic counselor is involved in your care. Individuals or couples may choose then to minimize the risk of transmitting the mutated gene to their next generation. And that includes needing to do family studies, potentially testing their partners, depending on what the conditions are and what the heritable pattern is of that genetic condition. In this scenario, the option of IVF is there where, again, eggs and sperm are fertilized in a lab. Embryos are cultured to a blastocyst stage. At that point, blastocyst essentially is day 5 to day 7 embryo, and blastocysts are made up of 100 to 200 cells. We now have the technology to do pre-implantation genetic testing, where we'll take 5 to 10 cells out of the area that one day would form the placenta and send it off for genetic testing. Genetic testing would correlate to the parental source of where this genetic condition are through linkage studies to find out whether or not that particular embryo is also affected by that gene. The alternative is to do prenatal diagnosis. What that means is that we're going to get pregnant. When we are pregnant, we then go ahead and do an amniocentesis or a chorionic villi sampling, so taking some placental tissue out when we're pregnant, or the amniotic fluid out for testing of the genetic condition. Individuals or couples might decide to do this and take this approach to better prepare themselves to what they're going to face or potentially consider termination of pregnancy. What does IVF look like? It starts off with taking injectables, stimulating the ovaries, trying to grow multiple follicles at the same time. The key milestone event in an IVF cycle is retrieving of the eggs using a transvaginal ultrasound scan with a needle on the side and puncturing of the ovarian follicles with the hope that within those follicle fluid, there are eggs. Eggs and sperm would meet in the lab and fertilize either through insemination or through injection. So there are 2 fertilization techniques there. And we mentioned also before that the sperm preparation could be fresh sperm, but could also be sperm that are previously frozen and banked. We then culture embryo and see the embryo develop until they reach the blastocyst stage. And we have the opportunity then to either transfer an embryo into a uterus or do not do the transfer first, but do PGT testing, which is pre-implantation genetic testing, select embryos that are not affected before transferring. Now, the last thing is this. Where the embryo is being transferred to may not necessarily be where the egg source was. And this could potentially look like transferring into a surrogate. What do we know about pregnancy and birth? We know that if you are affected by a physical impairment or intellectual impairment, that you are potentially at a higher risk of developing complications in pregnancy and birth. Things we need to think about is that the physical impairment may become worse as pregnancy grows. We may experience an earlier birth, so preterm birth, and this may be because the birth comes earlier spontaneously, or because of the condition where physicians decide to bring the birth on early on. So it could be what we call iatrogenic, caused by a decision that's made rather than spontaneously happening. We know that gestational diabetes is increased in individuals with disability that fall pregnant, but not so much maybe in the athlete group, but more in the general public, because we know that obesity has a higher rate in patients that have disability as well. Along with that, because of increasing weight and potentially pregnancy impacting mobility, that risk of pressure sore, clots in your legs and your lungs, we call that deep vein thrombosis or pulmonary embolism, can increase as well. Along with that, chances of urinary tract infection needing help to give birth using operations either through forceps, a suction cup delivery, or cesarean section is also found to be commoner in patients that have an impairment. We mentioned before just now that in some individuals may consider not carrying the pregnancy because of some of the risk factors that we've talked about and consider using a surrogate gestational carrier. The key to all this is planning and preparation and making sure that your family doctor or your long-term care specialist is involved, along with fertility specialists and all allied help. Pre-pregnancy counseling is key. What we talk about in pre-pregnancy counseling is this: if we're going to fall pregnant, how does the condition that I have existing affect an implanting and developing pregnancy? And vice versa, how does that pregnancy affect this condition that I have? Most patients would require medication review to make sure that the medication that we're taking are safe to take in pregnancy, or consider alternatives. There should be a very good antenatal care plan so that we try to minimize risk of, let's say, multiple pregnancy, right? An anesthetic consultation is usually required because physically you may be affected by scoliosis. Having an epidural may not be the most straightforward thing, and pre-planning makes sense. That alongside a birth plan and a postpartum plan. And how do you feel about breastfeeding? The challenges are in multiple levels. Could be biological, so directly with the physical impairment or intellectual impairment that you have. Could be psychological because of all the challenges that we've talked about or social stigma that arises with this. It may be the lack of awareness and the difficulty in accessing care. If we're thinking about third party, using an egg donor, a sperm donor, or a surrogate, this could also be quite costly over time. That's why we are here, because we want to learn about this. We want to raise awareness and want to open conversation. Because what we know is that there are advances in medicine today where individuals might not have reached reproductive potentials in the past, are that now they're in the reproductive age and we're able to care for them. And raising awareness also means that we're able to, over time, reduce stigma and taboo. If you know, then you can access earlier and you can explore, you can have conversation about them and make sure that you're getting the right care. You are the center of all of this, and everybody else is working in collaboration with you in the middle. And I put down some names and some jobs, but really there is so many, and this is not an extensive list. And that includes people like your fertility specialist. They might work with urologists, your OBGYN, your maternal fetal specialist, geneticists, counselors, surgeons, internists, and potentially, if we're going down third party, with your legal representatives. The conclusion is this: every case is unique and it's difficult to be very specific on the how. But I hope that today we have given you a good overview on the different degree of impairments, different partners, and the different family building visions that you can have. And each person is different, and even maybe dealt the same cards would take a different decision. Do the right thing for you at the right time of your life. The one common theme that I can emphasize enough is that in these scenarios, preconception care is key. Having a multidisciplinary approach is also key to your care. There you go. We have completed the webinar series, and I hope that you've benefited from this and also enjoyed it.
Thank you so much, Dr. Chong. That was really great to hear all about all the challenges and the differences for those with an impairment, or in a relationship with someone with an impairment, and things that they would need to consider. We do have a few questions in the chat, so I'm going to read them out. The first one is, are there specific fertility preservation options recommended for individuals with an impairment or a disability, especially those that may be managing a progressive condition?
Yes, fertility preservation, especially for those assigned female at birth, really is the earlier the better, because we know that egg quantity and egg quality, unfortunately, is a one-way street with its relation to age. And especially if it's progressive, the earlier you are able to preserve eggs, the better. Same with sperm. If there's going to be a progressive disease, then the earlier you can have some sperm frozen, or the more times you visit to bank sperm, the better, because it just opens up reproductive options. But broadly, to answer that question is fertility preservation will come in the form of egg freezing, sperm freezing, or embryo freezing. Embryo freezing, you're most sure about because it's out of the three, it's gone down a little bit more challenges to get to that point. It's more developed, right? Although it's more developed, it also is a little bit more restrictive in terms of future option because embryos tend to be co-owned by both where the sperm sources and all the egg sources as well.
Great. The next question is, are there any increased risks for the maturation of the embryo or during early pregnancy if the individual carrying the baby is in a wheelchair?
Yes, potentially. I think there are two parts to the question there because it depends on why they're in the wheelchair and the level and degree of impairment that they have. Slightly different if you have a lot of contractures and to maybe you have a limb impairment. So the degree of impairment's quite different, but can potentially be affected by pregnancy quite a lot because pregnancy, you will increase weight, you'll have changes in your posture. So preterm, whether or not it's brought on intentionally or whether or not it's spontaneous remains the highest risk, I think.
Great. Those are all the questions from the chat. I'm going to turn it back over to Dominique to wrap up.
Amazing. Thank you once again, Dr. Chung, for another very insightful and informative session. We're so grateful to you and the team at Markham Fertility Center. So once again, thank you. I just want to note again that the series are recorded and posted on both the CSIO website, specifically on our CSIO Resource Hub and the Markham Fertility Center. The links will be shared. And then I also want to encourage everybody to check out My Fertility podcast, hosted by Dr. Wise and Dr. Garcia. Thank you, everybody. Thank you, Dr. Chong.
Thank you. Bye.